Hey everyone, welcome to another episode of Medicine 3.0, your place for AI in medicine, precision medicine. This week, Dr. Adam Carewe. I had a great time talking with Adam. He is an informaticist, family medicine doctor, was at Kaiser Permanente, now working at a stealth startup. Excited to share this conversation. We kind of went all over the place, but I think super interesting conversation for people interested in medicine, precision medicine, healthcare, AI, all of the above. Enjoy. All right, Adam, welcome to the podcast.
Hey, thank you. I'm super happy to be here, Jared.
Well, I'm just going to start off. Standard question. How did you end up where you're at, knowing what you know?
Good question. I think I can give kind of the short, abbreviated version of this, but we can go into whatever more detail you want. But, I think big picture, if I zoom way out, I always have been interested in technology my whole life. I talk about it, my grandfather back in the, 80s when I was a little kid, he always had like the coolest gadget of the time. We're watching Stranger Things right now again with like my youngest, who now has the courage enough to watch it. And like the walkie-talkies that they use in Stranger Things, those like nice brick-sized ones. Like my brother and I had those, from my grandfather. He gave us a pair, and I don't know, I think it ran off of like 9D batteries, and the antenna was about 6 feet long, but we could use it and we could go really far on our bikes and talk. So I think that's like what I was like kind of brought up with. So that technology piece always lived with me. I started college in the late 90s, and, the internet was like just starting. And so I was like fascinated by that. And I taught myself how to make websites, and then I've always liked art. And so I taught myself kind of like digital art. And, all along the path, I ultimately decided to go to med school. And, but even throughout med school, there was always like this technology piece that kind of kept coming back. Any committee I joined would be, I'd be the technical, person for whatever the committee was. And then when I got into residency, I did my residency in Denver at St. Joseph Hospital downtown. And, they were going from paper to Epic. So that was the first time I had been introduced to Epic as an EMR. And, I just like threw myself out there and said, hey, are you looking for residents to help with this transition? I like technology. I'd love to make this system work as best as possible for, particularly the curmudgeon attendings that probably weren't going to be happy about this change.
Right.
I was excited about it. And so that was like my first dabble in informatics, I would say. I didn't know it was called informatics at the time, but it was helping people with those things. And, ultimately I joined Kaiser Permanente, right out of residency. And, probably about a year and a half in, I kind of stuck my nose in things too. And just, people finally said, hey, you really seem like you like this stuff. We have a team, that helps, our IT colleagues and our operational colleagues to make the Epic system as best as we can for clinicians and teams and patients. And I was like, well, that sounds cool. And so that's how I got into formally informatics and ultimately, became the CMIO.
Well, one thing I'll sometimes ask is what would you have been if you weren't a doctor? So I'm curious because you mentioned you loved art, you loved technology. Like, what do you think you would have done if you hadn't become a physician?
Yeah, I guess the one other part I didn't mention that I also did is in between that college and med school, I actually was on a path of exercise physiology. So I actually have a master's in exercise physiology and nutritional sciences. So that's actually the path that I thought I was going down. I think originally I figured I would be a teacher coach. I love teaching. I love coaching. I love helping, just helping people be better. And so I thought I'd do that. Because those were the models, the coaches I had in high school were also my teacher, like my biology teacher was my JV coach, and my, English teacher was, my varsity coach. So it's like, I kind of had this model of like these really cool people And so I went to college thinking I'd be a teacher coach, but then it like pivoted to exercise physiology because I was like, oh my God, there's an actual field. Like I played basketball in college too. So I was like into sport, into training, trying to make my own self as best as I could. Because, I didn't have the most gifted vertical jump, but I knew if I tried really hard, I could probably improve that. Um, and so I think I probably would have gone that direction. Um, but then, I think in hindsight, knowing like the way technology went, I probably would have, I don't know. It's one of those things. If you could rewind, like, would you maybe consider doing something different? And I don't know. Maybe I would have gone into like software engineering or some sort of engineering core kind of background because I love solving problems in that way. So I think I have an engineering mind too. But yeah, so I kind of went everywhere there: exercise, engineering, art.
Yeah.
I like doing a lot of things.
I was going to say, it seems like you have the ability to go pretty deep in a lot of different ways, which I mean, doing general medicine is one of those things. Now, you did family medicine residency?
Correct.
Yeah. So I mean, I'm emergency medicine, family medicine, emergency medicine. I think of us as like we're the kind of people who love to like learn about everything.
Yep.
And I think that's, sometimes it can maybe limit our earning potential because we're not super specialized. We're not like as rare as some other people out there. But I think it lends to really understanding problems across medicine in a different way than other people do. So I'm curious, like when you started kind of sticking your nose into informatics and technology and medicine, did you ever have like something that you figured out that like your skill set helped you figure out that other people didn't really like see the problem or they didn't really recognize it like you could?
Yeah, that's a good question. Yeah, I mean, I guess, yeah, I do. I think there's things that sometimes I'll see where like to me, it kind of seemed like obvious, but then it was something that like didn't exist. And so I think, I mean, a simple example of that was, right when I joined the team in Kaiser, this physician kind of, it wasn't even called informatics at the time because it was before that time. I think, Kaiser calls their Epic Health Connect. And so it was like essentially the Health Connect physicians team, essentially. And, it was a small group of kind of nerdy tech physicians that liked this stuff and wanted to help. But so when I joined that team, I kind of got hired but I wasn't hired into a specific role, because my boss at the time, who's now retired, but I still keep in good contact with him. He, when he interviewed me, he's just like, yeah, he's like, we want you on this team. But he's like, we're kind of evolving. We don't, I don't know exactly where I'm going to put you, but I want you to like kind of observe and figure out, what you think needs to go be next for this team. And I was like, okay, that sounds super fun. Kind of that engineering mind again, like observe the problems that are out there and try and create something. So, you might be thinking I'm alluding to something that's like really mysterious, but my biggest observation was two things. There wasn't really good, regular, trusted communication when it came internal communication around like how to best use the electronic health record, or, the new features that were coming, or the things that people could personalize to like make their day better. So that was one big observation. And then the second one is kind of tied into that. There wasn't like a really good training program, for particularly physicians, but everyone, like on just how to use these tools the best they could. And, I think I had just read like the checklist manifesto, and so I was like kind of thinking of like a pilot and thinking about how pilots have to go through all this training and regular kind of training and go back in the simulator. And, if that plane gets a software update, they have to all get recertified and like show that they can fly the plane. And I was like, how come medicine doesn't have that? We put a new version of the EHR in and like we just send out an email that says, hey, there's these buttons have moved and this is like what you can do now. And I was like, why aren't we training physicians how best to use the system to lead to actually better patient care and, more satisfaction in their job and everything else. I've always said, I think if you make physicians as happy as they can be, it's going to lead to better quality care, better experience, and hopefully better job satisfaction, less burnout, less moral injury, all those things.
Yeah. That I that is actually a really interesting kind of taking checklist manifesto, thinking about pilots, thinking about software. That isn't a way that I've necessarily thought about it, because the change, you and I both experienced this change from paper to software in medicine. Yep. And it was almost like we tried to make software, we tried to take pen and pencil and paper and say, this isn't going to be a big deal. Like, you're going to go from this to this computer thing, and it's going to be easy. You've used computers in the past. And we didn't really tell doctors, like, you're going to have to get certified. You need to be able to use it really well, because we believe that there's all these powerful things in it. It was really like, this is the pain you have to go through, and we're going to try to make it the least painful possible, instead of, we want to make you a master of this thing so that you can wield it like a tool. It was really like, how can we make it as least painful as possible, which is, I like that framing that you put out.
Yeah. And actually that is what I experienced as a resident. I told you that's when I transitioned from paper. And I'll even say, like, our hospital, I think they were doing the best they thought they were doing at the time, but like, they even did, Epic, I don't even think does this anymore with their rollouts and go lives, but we did like a staged go live. Like, they went live with Epic, but they still did order entry on paper, for a while, because it was like, they didn't want to, like, to your point, they didn't want to, I just turned on my Zoom. Now it's going to go crazy on us. I use my hand gesture. But, they didn't want to disrupt, those attendings. And I just remember as a resident going like, this just seems so weird. I'm like, if anything, we should have done order entry first. I was like, that's the thing that's so much easier to do, but I don't know. But no, I get, it is that back to that point that I just, I think there just wasn't there wasn't as much of an investment in that kind of actual training and optimizing of the people. And that's ultimately what I built, in KP Colorado for the med group. And then, ultimately it spun out bigger, but, I called it, we kind of crowdsourced the name of it, and we called it the Site Symposium and the Site kind of curriculum, CITE. And it standed for clinical IT efficiency, because I think that encapsulated, what it was. And it wasn't just the EMR. It was like, how do you facilitate a visit with a patient, in the ambulatory setting, so it's the best and the most efficient. How do you pre-chart the best? How do you pre-review the best? How do you create your own preferences and orders, and, your own templates, and how do you best use the system content, that, these systems put a lot of effort into making. How do you combine all of that to make yourself a super user? That's really what the goal of that program was, and, still is, even though I'm not with that organization anymore. The program lives on.
Yeah. Why do you think medicine has struggled? Like, when you think about like the best software you use, like, it's mostly invisible. Why do you think that medicine has struggled to achieve that kind of beautiful software that we experience in kind of the commercial part of our lives?
Yeah, I actually get asked that type of question a lot, especially from like angry physicians, like,
exactly,
why,
right?
Why can't this work like my iPhone? Uh-huh. And so I usually answer it in a couple ways. Number one, like, the software that was initially delivered to us in healthcare was not necessarily thought in the same way that consumer software, I think, is developed now. I think what's hard is like the two things, like, even though they both have existed at the same time, there's like a different time frame to each of them, like their development cycle. And, I think back, like, and there was like regulations around it and all sorts of like, things that I think were well intended, like for meaningful use and those types of things that, kind of pushed the way like these EHRs and systems were developed. I think what's super interesting now, like to your question though, like with ambient AI, like just as an example, we actually are getting to that place of where, wow, this some of this stuff is disappearing to the background. Like my clinical work right now, I'm using one of them. I won't name their name because I don't want to give favors or anything, but I'm using one of those companies, and um, I'll just say, like, it's to have a video visit with someone and literally just talk to them for like the 10 minutes that it takes, or however long it takes, like really explain to them what I'm thinking, what I think the next step should be, do like shared decision making, and not have to touch my keyboard at all. Like I finished that visit and I'm like, I have trust, that system just listened to everything. And yeah, it's not going to get it 100% right, but I know it captured everything. It's like, that is like, I feel like it's reached that first kind of magical moment. Um, but yeah, I think it's just healthcare was had a different set of rules that the software companies had to live by. And frankly, they weren't like designing it for an elegant UI or UX. It was, they were designing it for, what it was initially, which was like a billing system and a compliance system and those sort of things. I have confidence that the EHR will eventually disappear to the background, like you said. Eventually it will, and I think with appropriate technology. But it's going to be a while.
Yeah, it's been really interesting to watch over the years, because I don't know how many times you and I heard that like Silicon Valley is going to disrupt healthcare, but it's been a lot, right? Like,
Yeah,
there's been efforts by every major company to kind of disrupt healthcare. I think Apple has been kind of the slowest to try it, and because of that, they haven't had a big failure yet. But I also think technologists underestimate how complicated healthcare is, and
absolutely.
they just assume one app that I really like on my iPhone is the Reminder app. Like, it's super simple. I can access it through Siri, but it can be fairly powerful. But it's really, really simple. And in EHR, like there are like, if I just like voice ordering, right? Like if I order a medication, I still need the, interaction check to happen, the allergy check to happen, the insurance check to happen. Like there are all these different things that need to happen so that I approve something and say that it's okay to order. And I think technology companies sometimes, well, they have underestimated the complexity of healthcare. I don't know. What do you think about that?
No, I mean, I agree with 100% of what you just said. It's a really, I think it's a great observation, and it's true. I think too, I mean, this is a bias, but I think those of us that live in this like straddled technology and clinical space, like actually know and understand and frankly work still in the clinical space. And we understand enough of the technology side. Like, back to your question, I think the reason why some of these companies have failed is I don't think they had the right clinician-technologists that were actually a part of building it. So to your point, it's super well intended. There's amazing, brilliant people out there that are creating all sorts of great, solutions and products, and, to fix a variety of things, including the Googles and, the Apples and everyone else and Amazon. But I think, like, I don't know. I just think so far, like none of them have been, tackling it in the right way, and not, I think just maybe not involving enough of like the actual clinician, like driving force. I just, I saw that internally in my old job, like anything that was like, say operationally they wanted to do. If you involved IT, that would help, because IT people would kind of, somewhat understand, okay, you're trying to do this. Well, we have these kind of widgets we can use. But the superpower was when they involved the nurse, the physician, and the pharmacy informatics folks, because they're the ones that can stitch it all together. And I think that's like what's still missing in health tech, like, outside of like health systems, is I think they're missing that piece still. I mean, I think there's a lot of people that are trying to fix that and work in that space, but I think that's the part that ultimately make or breaks things.
Yeah. And, it's cool because I think, 10 years ago when I started my first company, there were very few clinicians leading companies or working at the top of technology companies. And you and I are both part of communities now where there are lots of physicians
Yeah.
nurses, physicians, et cetera, who are trying to become involved with these technology companies, and they straddle, like you said. Many of them are computer scientists plus clinicians, or they're informaticists and clinicians. And I think we're at a completely different phase. And I think it's such an exciting time because the technology is getting so much better so quickly, and we have the right talent to really change healthcare. So with that kind of framing, I'll kind of pitch it to you. Like, what are you most excited about over the next few years as far as technology in healthcare and where you think it's going?
That is a great question. And I think, I think about this kind of stuff a lot. And I think I'd say, I mean, this might sound a little bit outlandish, for some people that are listening to this, but I think there's actually going to be a significant disruption in healthcare, like in like the next few years. And I think it's kind of a combination of what you just described. There's more clinician minded folks that are kind of really going into this and trying to really get at fixing this. I mean, I throw myself in there included. I have aspirations to do this. And I think the combination of that with the combination of where technology is going, and, the way artificial intelligence is accelerating, I just think this like level of expert technical knowledge is going to like vastly surpass, even the smartest doctor. And I know people like hate when, someone says, oh, this technology is going to replace, X, Y, and Z physician, and I actually do believe that, not in the sense that I think physicians are going to go away, but I think it's like going to completely change how physicians work. So, like a radiologist isn't going away, but their ability to read scans is going to look a whole lot different in a short amount of time. A primary care physician, right now they're limited. I mean, even the best primary care physician really can't have more than like 2,500 patients on a panel. And that's, I think, frankly, a stretch. I think we'll be at a place where, a primary care physician will be able to have 10 to 20,000 people that they take care of, in quotes, but it feels like a concierge practice where they're only taking care of 200. Like, I think there's going to be something that comes along that helps that. And that's like what I'm like kind of focused on trying to think about and figure out how to build as well.
Yeah. There's some giant leaps that have to happen for that to be true. I kind of put you and I in the bucket of like technology optimists. Like you and I are very well aligned on, we think this disruption is coming and we both want to be part of like helping this disruption happen, just because, that it needs to happen for our country, for our patients, for our physicians, for all of us.
True.
But there is this strong pushback, and both of us see this on social media, on LinkedIn, et cetera, where people are bemoaning that AI is not as smart as we all think it is. It's not going to disrupt. What do you kind of say to those people who kind of pitch that today?
Yeah, I love that. Like, I agree. The way you framed that up and said we're like this, like kind of future optimist kind of way. I do, because when I hear people saying that, it just honestly, it brings me back to that video of Steve Ballmer, like a day after Apple announced the iPhone. And I recently found that video and I made I reshared it because it is like, I feel like when people are saying that right now, we're going to replay or look back on LinkedIn or Twitter or whatever and see these posts. And I think these people are going to feel, frankly, they were wrong. You know, like I really do. And it's not like, it's not bad. I mean, because I think all of this has to be done with extreme caution and carefulness. But I think what people aren't looking beyond is like the state we're in right now. You know, the state we're in right now, I agree, is it's not great. You know, like they'll even say you'll see stuff that ChatGPT will do, and you go, oh my gosh, that is like superhuman. And then the next sentence is something that is like so dumb, you know, like Peter Lee, I mean, I think had that famous quote, right? It's the smartest person in the room and also the dumbest, which like that has to be fixed. But assuming that that can be fixed, and I will hedge that it will be fixed, like, um, I think like, I guess the way I put it is like, you know, I've heard this said before too, like, you know, the joke that what do you call the person in med school that graduated last of class? You know,
Yeah.
they're a doctor, right? They still are a doctor.
Yep, they're still a doctor.
Yeah, but do patients want to like know that their doctor finished last? Well, I think artificial intelligence is going to like level set that doctor field, you know? So yeah, the people that crushed med school and, you know, could just memorize a whole litany of facts, you're not going to have to do that, you know, in the near future. So
right.
I just like, that's like the future that I think is coming. And, you know, I think if people say that like, use the words like never and it can't, and like, I just think you're going to eat your words at some point. And
right.
That's generally, and I'm generally nice, but on LinkedIn when I'm replying to those things, but I do kind of push that opposite kind of message that don't be the Steve Ballmer, you know, that said the iPhone was dumb because it didn't have a keyboard and wasn't made for business customers. You know, who's laughing now?
Yeah, exactly. And it's interesting. There's this trade-off today in AI between speed and accuracy, right? Like if you're willing to use a multi-agent system and use multiple GPT-4s answering a question, it might take 2 minutes, but it's going to, then you only have the smartest person in the room because it'll catch itself from the dumbest person. And, but that will just get faster and faster. And pretty soon,
Correct.
I think we're seeing this you'll hear people talk about engineers and developers, and they're probably not going away either. But the developer who is really good at using AI probably replaces the developer who doesn't use AI at all. And I think that that's what we're going to see in medicine is we're going to see the physicians who are able to really embrace AI and use the tools that their health system gives them and that disrupt us. They're going to be better doctors. We may not replace, you know, the doctors who don't want to learn AI, because there's going to be patients. There's going to be patients who never want us to use AI on them, or there's going to be patients who don't trust it. But I think there will be, you know, the doctors who embrace AI will be able to do more good for the world.
Totally, 100% agree. I've actually said those exact words a few times. The whole like replace that. I said that really early. I remember like even when I first, you know, like that first moment where we all like tried ChatGPT and like were floored. And I can't even imagine what it was like for those that got like early access to the next models, or the ones right now that are having access to the next models. Like, I'm sure like minds are being blown, you know, in a lab somewhere. And, yeah. And I was saying that same thing. I mean, I was like, yeah, you know, like right now you can still be a doctor and have a paper practice. And I actually, I mean, there's an OBGYN right where I live, and he has his own practice and he still uses paper and he is just chugging along and doing fine. I don't think anyone's going to buy his practice when he retires. Like, I think maybe he was probably hoping for that, but I think that ship has maybe sailed. But yeah, I totally agree with what you said. I mean, I think it's just, you know, and that's like me. I've like always I guess I would be considered like the fringe early adopter of technology, which I don't expect everyone to be like that. But you eventually have to get on the boat, like the people that resist are ultimately the people that are going to like lose, like there's just so many stories in history of companies that made that mistake. And I think people will make that same mistake too. Don't become the Kodak or the Nokia or, whatever. Like if you say the competition is crazy, you're probably in trouble. Like someone's gonna leapfrog you. And I think healthcare needs to like do that too, because I think there's going to, like I said, I think there's going to be something that comes along that's going to just be this, leap in what we currently can do. It's going to be just this, layer above what the best we can do right now in prevention and population health. And it's going to be this like just very specific, personalized, uber preventative, and actually prevent like disease down the road. Like let's just get to a place where like we don't have like heart disease anymore. Like I think that's possible. It would take a ton of work, but I think that's what's going to come around and be so disruptive, and become mainstream. And people that are investing in giant hospitals, I've said this too publicly, like I think hospitals will eventually like diminish. Like I just think we'll get to a place as a human species that we can prevent things that really require frequent hospitalizations. And if that's the business model you're in healthcare, at some point you're going to be in trouble. Obviously not imminently, but I think that's the path that we're going down.
Yeah. There's definitely still a lot of money to be made with hospitals, ICUs, but I agree. I think, we're going to be finding cancers earlier and earlier. Hopefully, I mean, it's going to take some public education on living healthier lifestyles, but things like GLP-1s that are making it easier than it's ever been for somebody to be metabolically healthy and start preventing diseases. Drug companies are highly incentivized to keep finding drugs like that are bigger and better and faster at delivering those outcomes. So I think it's a super exciting time it kind of across the board. You've got biologics like GLP-1s and new drugs and immunotherapies for cancers and screenings and new technologies and all sorts of really cool things coming down the pipeline.
Agree. I just think it's scary on one hand, all this like genomic potential, that we all have. Like if everyone had their full like, genomic profile, what could we be doing differently? Like we would know what medicine they're going to metabolize, better. And we would know what blood pressure agent is the best one to start them on. Not the gold standard, like not lisinopril or hydrochlorothiazide or whatever. It's like, for this person, it might be you start with a calcium channel blocker, and like, because it's going to be the most effective. But we do this like trial and error in medicine. Like, I think people think medicine is like super scientific, which obviously it has tons of base in science, but it's like way more art than science and way more trial and error. And I think we can get to the point where there's a lot more certainty, a lot more specificity around testing and screening. And I think that's what patients actually want. Like they want to be scanned and to be screened, and like, they don't understand why when they come to a doctor and they go, well, can't you just order all the tests? Like, I want to make sure everything is okay. And you have to have this talk with them like, well, yes, we can do that. But like those tests are not specific enough, at right now. But I think that's changing, like obviously the sublipids that can be tested and, these things that can really kind of fine tune how someone, is kind of treated and incentivized to make their body healthier. I think we're like on the precipice of like, I think that wave. So yeah, I think there's a lot of stuff that's probably going to change in our lifetime, and it's going to be ultimately for the better. But people are
Yeah.
going to have to change significantly, and society
Right.
is going to have to change. Like,
Yeah.
we don't have to go to the
Yeah.
rabbit hole of the food industry, but you know, the food industry needs to change. Like, it is
Right.
so corrupt.
Yes.
um,
Yes. I mean, honestly, my biggest concern is not the technology, the medicine. It is like society paying for these therapies. How are we going to incentivize people to do the right thing? I think
yeah,
exactly like you said, people want like very personalized treatment. And even when you look at guidelines, like blood pressure guidelines, diabetes guidelines, and you start looking at, because for those not in medicine, we grade our evidence, right? And it's A, B, C evidence. And usually like the first couple of guidelines are level A evidence, like randomized control studies behind them. But then a lot of it is expert opinion evidence driving our guidelines. And when we have genomic data, when we have lab data, when we have wearable data, when we have all the data in an EHR like Epic that covers more than half the lives in the US, like 70% of the lives in the US, like and now we have health information exchanges and TEFCA, and now you can have like big data working on the individual. Like it's
yep,
such, like we can start having super precision medicine for you. And just like you said, like when we start you on a blood pressure medicine, it's not one of five that I would do for anybody. It's the one I would do for Adam.
correct.
So I think that's a super exciting time to be headed
Yeah,
into.
totally agree. It's that level of personalization that people truly want, but like we're so close, but we just don't have it quite yet, you know, like to that level. I mean, obviously there's opportunities for people to do that, you know, in different like longevity type of, you know, practices and things, which, you know, I think are great. And I think what those are going to do is those are going to slowly, like all things that are innovative, you know, they're going to slowly become like that more mainstream piece. Um, and yeah, I mean, I think that's what I want, and I think I really do. I think that's what people want in general. Um, and yeah, because I think people want to be healthy, like you said. It's like they want, you know, like the grocery stores. You know, I feel like the new, more modern like grocery store that's built, like they actually are putting like the produce section right in the front, like it's right when you walk in. You know, I think of like there's a Target near me, there's like a Kroger, King Supers near me that, you know, is built that way. But then what's right in the doorway when you come in? It's like donuts, cookies, like sodas, you know, and I'm just like, this is like, I was like, that has to change too, you know, and so, and because I mean that type of the bad food choices are so cheap and easy and accessible, and you know, I think we need to find a way to be able to provide better food for everyone in like, I don't know, call it an incentivized way or maybe even a subsidized way for those like less financially fortunate. Um, like we need to find creative ways to do that because I think that is what's going to change. You know, I was recently having lunch with someone this weekend, and he was talking about his wife is a pediatric endocrinologist, and it was like we didn't talk about it for a long time, but it was like, I mean, he said it's sad. I mean, there's, you know, he said his wife has, the majority are diabetics, but the growing pool that they are taking care of is type 2 diabetic kids, you know,
That's crazy,
with,
right? Yeah.
yeah, with like, you know, BMIs off the charts,
Right.
and like already showing signs of kidney problems, already potentially showing signs of heart problems. I mean, as a kid, like that's
Right.
terrifying. And
Yeah.
a lot of those kids, you know, are coming from, you know, a disadvantaged, like kind of socioeconomic, historical, whatever geographic area. And it's just, it's not fair. Like, I mean, I think we need to level up
Yep.
um, everyone. So everyone has a fair chance.
Yeah. And I mean, when you look at, and you said this, we could spend hours talking about food industry and when you look historically and you look at our weight, our blood sugar, like over the decades and what has happened in the US, and people in the food industry would argue like, oh, it's not just the things that we've done. It's not just that we've made hyper palatable food with super calorie dense and increased, corn syrup and everything. But I mean, that is a huge impact on all of our health. And then, like you said, the most vulnerable, if I'm going to the store and I need to feed a family and I'm on a budget or food stamps and I need to do it with hyper palatable food that is calorie dense, and maybe I can't afford like the organic vegetables. And I think I'm very interested in, food as medicine, and I'm very interested in that movement. I think, but also there's so much education that's going to have to happen there to convince people that they want to actually eat that food. And a lot of that is just in the US, we often just say, and it's that libertarian streak in us, and I think we all kind of have it, like we want people to have the power to decide, but then we also allow the market to push things that aren't great for society. So it's a catch-22 for sure.
It is. And I think it's like, I don't know, how do I word it? It's a conglomerate of misaligned personal incentives.
Yep.
And then the way like our healthcare industry is currently modeled, it's basically modeled to take care of people that get really sick,
That's right. Yep.
We always hear the sick care model, which I agree. It's like, that's the way it's set up. And like, but what if what if some innovative insurance company came along and was like, hey, it's sort of like, when you get life insurance, if you're a non-smoker and, you have a good cholesterol, you don't have evidence of prediabetes, you're going to get a really good rate. Like, why isn't health insurance that way?
Yeah.
Like, what if you can prove that you do 5 days a week of cardiovascular exercise and 2 days a week of strength training, and you can show, like, I don't know, you got to take pictures of like your plate of everything you eat, and the AI analyzes that, and like it proves to the insurance company that you're healthier, like, and you actually then get a benefit out of it, a financial benefit. Like, I think that type of stuff and that innovation would like drive the needle for change. But I mean, we are humans, we operate off of incentives and
that's right.
They have to be some sort of incentive that's beneficial to you individually for change to actually happen.
Yeah. And I've thought about this a lot. I mean, and I believe that life insurance is honestly the best aligned insurance with health because they 100%. Want you to live. And
correct. They're fully incentivized. You're mutually incentivized, right? Like, they want you to live as long as possible. Yep. And you want to live as long as possible. You want to have this security in case the accidental happens.
Yeah.
And current health insurance is not that way.
No. I mean, for the most part, health insurance, they're constantly gambling that they're going to get you off their rolls before something terrible happens. And correct. The average is 18 to 24 months that somebody is on their rolls. And so like their incentive is, to kind of pass you on as quickly as possible. And then you end up on Medicare and you cost everybody pays the price.
So true. Yeah.
Well, Adam, this has been awesome. Where can people follow you, learn more about you?
Yeah, I mean, so I have I would say two kind of publicly, best places. One, I'm very active on LinkedIn. So if you follow me or connect with me, I'm happy to always connect with people. I basically just hate it when I get connected to someone and they immediately pitch me their product. Like, don't do that,
sure.
Which I know happens. But, if you truly want to connect with me and learn together in mutual ways, connect. But otherwise, just follow me. So that's easy. And then, I have a Substack too, which my nickname is Rewski, Rewski. So the Substack is called Rewski.com, like spelled out, DOTCOM, .substack.com. So I blog there. That's like where my podcast, my NerdMD's podcast is too. So that's I think a great way to kind of read and learn more about me and connect in that way too. And yeah, I think those are the two best options.
Awesome. Can you tell us the story behind Ruski? How'd that come to be?
Yeah, no, that's a good one. So my last name is Carewe. Everyone pronounces it Carewe or Carewe, or I get a bunch of derivations. But the final E is silent. So it's just CA and then REW. Well, when I played basketball, like I mentioned in college, and there was a player on my team named Bobby, and he was the guy that gave nicknames to everyone. He's just kind of this very extroverted, outgoing guy. Super fun guy. Actually, I haven't followed up with him in a while. I should probably reach out to him again. But he kind of gave everybody, nicknames. And yeah, my freshman year, I think he was a year or two ahead of me. And he just started calling me Ruski. And I was like, yeah, dude, that's cool. And I remember even back in the day, after he coined that, I went out and bought that URL,
That's awesome.
So I still have Ruski.com. If you go there, it actually, I think it points to my Substack. Yeah, I mean, for a while, my whole family had Ruski.com emails. I just gave them little aliases. And but yeah, that's the genesis of Ruski, and it allows people to remember my name, I think, a little better too.
I love it. Adam, thanks so much.
Cool. Thanks, Jared. Appreciate it.
Thank you for listening to another episode of Medicine 3.0. We make this podcast so that you know where to turn for good information on keeping you and your loved ones healthy. Feel free to check us out at bionichealth.com, where we can help you live a longer, happier life.